these are the disclosure slides. So I have done quite a bit of clinical trial work, and so I do have some relationships with industry. I'm not going to be speaking about any of the particular products that have been developed in those clinical trials, most of which have to do with the treatment of cognitive symptoms, although we have done some cognitive trials in behavioral and psychological symptoms, which are very challenging to do. So one of the reasons that we always say more research needs to be done in this field is that it is very challenging research to do. The program itself, I think you've seen these slides before, has received financial support from PHAC and from the CCSMH in the form of an educational grant. The program goes to great lengths to try to get a variety of perspectives here. So what we'll talk about today is these learning objectives, and I'll kind of put them more in an outline form. We're going to have a brief overview of behavioral and psychological symptoms in Lewy body dementia, and then I'll talk about the management of Lewy body dementia, and then a brief overview of behavioral and psychological symptoms in the frontotemporal dementias, and cover the management of BPSD in, that should be FTD, that is a typo, sorry. We will not cover vascular dementia for multiple reasons. One is time, and also vascular dementia itself is a heterogeneous condition, and there are very few studies that are dedicated to the specific management of BPSD in vascular dementia. The management is often considered similar to Alzheimer's disease given the high prevalence of mixed dementia, but it's also an area that's ripe for study. So beginning with Lewy body dementia, and here the terminology gets confusing. So Lewy bodies are pathological inclusions of a protein called alpha-synuclein that are found in a subset of neurodegenerative conditions. And so if you take that entire subset, you talk about the Lewy body disorders, and they come in two major flavors, one of which has predominantly physical symptoms, and that we know as Parkinson's disease. There are other Lewy body disorders that are more rare, such as multiple system atrophy as well. And then there are Lewy body disorders where the symptoms are mainly cognitive, and these are also grouped more broadly under the umbrella of Lewy body dementias. There is a condition called Parkinson's disease dementia and dementia with Lewy bodies. Dementia with Lewy bodies has a very specific set of diagnostic criteria, whereas Parkinson's disease dementia is the development of dementia in someone with Parkinson's disease. But I think they're essentially the same. There's an arbitrary cutoff that if you develop your motor symptoms within a year of developing the cognitive symptoms, then you have dementia with Lewy bodies, whereas if you have motor symptoms for at least a year before you have overt cognitive symptoms, then it's considered to be Parkinson's disease dementia. So why do these conditions all present somewhat differently? Well, one of the proposed models for how Parkinson's disease develops that has really come out in the last decade is this idea that the Lewy body disorders may present with a brain first pathological type and a brain first pathological type. And it's thought that in the proportion of these conditions which are not genetic, which is the vast majority, something in the environment, environmental toxins, can either be inhaled and therefore start the brain first progression of Lewy body diseases, or they can be ingested and they start a progression of Lewy body diseases that starts in the gut and then goes into the enteric nervous system, the autonomic nervous system, and the brain in a different type of order. And it's felt that perhaps these two pathologically distinct progressions of the disease lead to different symptoms. And patients who have body first Parkinson's disease are going to have faster progression, faster cognitive decline, more symmetric motoric symptoms. So these are the patients who develop more of the Lewy body dementia type symptoms. That might be an explanation as to why you get these different types of diseases from the same underlying pathology. There's also another spectrum underlying all of this, wherein patients who have dementia with Lewy bodies also frequently have coexisting Alzheimer's disease pathology, such as beta amyloid plaques and neurofibrillary tangles. And so this has been shown in studies where they're looking at biomarkers, because we can now, at least in research settings, get markers in cerebrospinal fluid, for example, or in some advanced imaging techniques where we can determine in vivo in a living person the burden of Alzheimer or Lewy body pathology. And the mix of symptoms that you get, whether you get really predominantly some of the symptoms more associated with Lewy body disease, or whether you get predominantly symptoms that are more associated with Alzheimer disease, depend on the relative burden of the pathologies. That makes sense. A lot of people are in the middle, and so they get a little bit of that and a little bit of that. And this is why frequently in clinical practice, we have patients where, strictly speaking, they don't meet the real criteria for Lewy body disease, but we know that there's Lewy body rumbling in the background, and there's many of the ways that they're presenting make us think of that. So, what are the common behavioral and psychological symptoms in Lewy body dementia? And here I'm going to highlight the common symptoms that differ somewhat from the ones that we see in Alzheimer's disease. The symptoms that we see in Alzheimer's disease can be seen in all dementias. So one of the diagnostic criteria, in fact, for dementia with Lewy bodies is fairly significant fluctuations in alertness or attention. So this is somewhat different than what we can see in Alzheimer's disease qualitatively. These fluctuations can be quite dramatic. They can occur over days or over weeks. And in fact, it has not been uncommon in my practice or in my career to see patients who are eventually diagnosed with Lewy body disease. And you see initially on, they've had 5, 6, 7 presentations to the emergency room with unexplained decreased level of consciousness or unexplained delirium, and then it's over time that the other symptoms of Lewy body become more prevalent, and we understand that these presentations with delirium were actually these fluctuations. There is REM sleep behavior disorder, and my colleague Ron Postuma in Montreal, as well as many others, showed that in fact this is a symptom that often predates other symptoms of alpha diseases, sometimes up to a decade before. But if you don't ask specifically about this, patients often may not tell you, and you may not be aware that they're experiencing REM sleep behavior disorder. So for people who aren't aware of this condition, this is a condition where during REM sleep, which is the part of sleep where we're dreaming, there is usually atonia that's generated in the body through a mechanism in the brainstem. So you're dreaming that you're chasing a bear or that the Vikings are after you, but your body is totally paralyzed during that dream. That mechanism is not working during REM sleep behavior disorder, and so this leads to violent movements or vocalizations during sleep. And these can sometimes be quite dramatic. Very often they will lead to a bed partner now no longer being a bed partner, and in severe cases, patients may injure themselves by falling out of bed or punching through the headboard or that sort of thing. But again, when a patient is presenting because of cognitive issues or because of motor issues, they may not put two and two together that this is even an important symptom complex to discuss with the clinician. So you need to bring this out of them. Anxiety is very common, and the anxiety here in some patients seems to also be qualitatively different. It's not anxiety about specific things that are happening or ruminative thoughts. It's this feeling of inner tension and just constant anxiety. And that can also fluctuate. And there's been some research proposing that this actually represents a cognitive behavioral form of some of the motor fluctuations that patients with Parkinson's disease experience as well. So I think that's true in some patients. And the anxiety may also correlate with those motor fluctuations, in that patients who have profound motoric symptoms, if they're in an off state, obviously they will feel very anxious. So anxiety is an important one. And also, like the REM behavior disorder, anxiety may predate other more overt symptoms of the Lewy body disorder. So you may hear about patients who are developing this generalized, non-specific anxiety for a few years before they develop other symptoms. And depression is also common. And again, sometimes this is sort of quote unquote endogenous depression, where the patient is experiencing anhedonia and flattened affect and vegetative symptoms for no real clear cognitive reason, but often it can be a reaction to the other symptoms that are happening as well. And then hallucinations are another core feature for the diagnosis of dementia with Lewy bodies, for example. And in the diagnostic criteria, they talk about well-formed recurrent visual hallucinations, very often of living things. So very often people, animals, and sometimes they can be a recurrent state. So it's not uncommon to hear a story where there's an extra table setting now set up because there's a visitor living in the home. Often before these more overt visual hallucinations develop, patients describe what are known as extracampine hallucinations. This is a feeling that someone is there and you can just feel their presence in your peripheral vision, but as soon as you turn to see them, they're not there. So you're not actually seeing the person, but you have a real feeling that there are other presences there. This predates visual hallucinations, and again, this is a symptom that patients don't often describe unless you ask them. And then, of course, there can be hallucinations in other modalities such as auditory, tactile, gustatory. These are more rare. There are other visual perceptual symptoms, and there are delusions that are mediated by visual perceptual symptoms. So metamorphosia, which is not an actual hallucination, but the shapes and the outlines of objects and things in your environment are shifting around. Reduplicative paramnesia, which is a delusional belief that you're seeing a scene or something that is an exact copy of something else that exists in the real world, which is kind of an interesting thing. Sometimes the basis for persecutory and delusions of jealousy actually stem from visual perceptual issues where, if there is someone in the house and they're a good looking person, then you might start thinking that your spouse is having an affair with you, which is why this stranger is always there in the house. That's not always the basis, but it can be. And then there are these rare delusions such as Capgras delusion, which is the feeling that a person that you know well is actually an imposter impersonating that person, or the Fragoli delusion, which is where multiple people are actually all the same people. And these may have basis in visual perceptual processing as well. So how do we manage these? Well, studies are lacking. And especially in behavioral management. And so we often adopt similar principles as behavioral management of BPSD in Alzheimer's disease. This seems to be a reasonable approach. ABC, what are the antecedents to the behavior? What is the behavior itself? Can we describe it? Is it really agitation, or are they responding to a delusion or a delusional belief? Are they responding to a hallucination? And then what is the consequence of that behavior? And does it really warrant any type of intervention? And if we understand the antecedent and the behavior itself, we can tailor our intervention. And obviously, if something starts like the fluctuations or like these hallucinations, you want to work up to ensure this isn't a delirium triggered by an underlying medical cause. And once they've had a good medical workup, then you want to identify and address triggers in the environment, understand if the BPSD has a meaning in the context of that patient. And if it does, then try to address it, and then identify and address any perpetuating factors that may be present. And you want to reassess this behavioral plan with every iteration of its implementation. So it's all fine and well to come up with a plan, but you want to see, are you able to execute that plan, and is it having the desired response? And if not, start over again. In terms of actual studies, these are very few and far between. People wondered whether exercise can help both with motor symptoms and also neuropsychiatric symptoms in patients who have Lewy body dementias. And someone about 8 years ago actually undertook to review greater than 111,000 studies. And out of those 111,000 studies, they could identify 16 patients with dementia with Lewy bodies who had actually been studied and seemed to benefit from exercise. So we're far from knowing there. It's thought that with the fluctuations in alertness and arousal, that there may be circadian triggers to this. And so tailored light therapy has been proposed as something that may be effective in establishing circadian rhythms and reducing fluctuations. It's been proposed. There are physiological mechanisms that suggest it could be also effective in treating REM sleep behavior disorder, but there's no actual clinical trial evidence to support this beyond anecdote and extrapolation. But it's a reasonable thing to try. Light therapy, generally not harmful, but again, even behavioral interventions can always have undesired outcomes. So if you're going to propose this to someone, you want to follow up with them to see what are the effects that they're having. In terms of the pharmacological management, well, the cognitive enhancers, especially cholinesterase inhibitors seem to really be the first-line treatment for fluctuations, hallucinations, and delusions. Donepezil and rivastigmine have been studied the best, and rivastigmine had more side effects in this meta-analysis. So this is the most comprehensive meta-analysis I could see by Stinton et al., where they showed that overall treatment with cholinesterase inhibitors seems to be favored by the bulk of the 4 studies with 916 patients that they looked at, and concurrently withdrawing the cholinesterase have worse outcomes for patients as well. So you can see that they get better when you put them on them, and then if you take them off, they get worse again. So that does really suggest that these are having some help. And because there's an indication for the treatment of cognitive symptoms, I think most of us would agree that if we see a patient with Lewy body dementia who is experiencing hallucinations or delusions, the first thing we would do is try a cholinesterase inhibitor. Memantine has much less, has been studied less. There may be minimally useful. The meta-analysis for memantine did favor the intervention, but the confidence interval crossed 1, meaning we don't really know for sure if this is really effective. If the patient is experiencing psychotic symptoms such as hallucinations or delusions, if they're on dopaminergic medication, you can trial reducing the dose. So start with eliminating non-levodopa drugs before you reduce levodopa. Go slow, reassess, repeat, and stop reducing if intolerable motor symptoms develop as a result of reducing the dopaminergic medication. Sudden withdrawal, like abrupt discontinuation of dopaminergic drugs, especially in patients who are on significant doses of them, can result in a neuroleptic malignant syndrome-like crisis. So that should always be avoided. So you should always go slow if you're going to reduce these medications. And if that is not possible or it doesn't work, then antipsychotics can be considered. There are 2 small studies showing that quetiapine can be effective for psychotic symptoms in patients with Lewy body dementia. Quetiapine is well known and easy to use. Clozapine has much less evidence backing it, but is sometimes used because it does not have a risk of extrapyramidal side effects, but does require quite elaborate monitoring scheme. So it could be a consideration if you try a patient with quetiapine and they don't respond and they have very severe psychotic symptoms that need to be controlled. Other antipsychotics have been studied in small studies. They either significantly worsen the motor symptoms and or actually worsen the psychotic symptoms. So we avoid all antipsychotics apart from quetiapine and possibly clozapine in patients with Lewy body. And this is really one of the key distinguishing features from the pharmacological management of Alzheimer's disease. There are other avenues that are being studied. There is a drug available in the United States called pimavanserin, which actually acts on a specific serotonin receptor. It's a 5-HT2A inverse agonist, and it has shown effectiveness in a recent phase 3 randomized controlled trials. There were other trials before showing effectiveness as well. It is not available in Canada, and the manufacturer has no plans to submit this for approval to Health Canada for reasons that I don't know. So it's something we probably won't get access to. Interestingly, in Japan, after cholinesterase inhibitors, their guidelines recommend trying Yoku Kansan, which is a traditional Kampo medicine, which is the traditional Japanese medicine, very closely based on traditional Chinese medicine. And interestingly, Yoku Kansan works through modulation of this same 5-HT2A receptor. So I don't think we have a lot of experience with this out in the West, but this could be something interesting for people to study as a potentially safe treatment. Although, again, traditional medicines can also have lots of adverse effects the way pharmacological preparations can. The treatment for anxiety and depression, the evidence base is lacking. The management is extrapolated from the management of primary psychiatric disorders, but the neural mechanisms underlying mood symptoms may differ. So I described this already, that anxiety may sometimes represent a non-motor off state. A small study using citalopram was not effective and had high rates of withdrawal due to adverse effects. One randomized control trial with a small group of patients of duloxetine in Parkinson's disease dementia showed effectiveness on treatment of depression. So perhaps an SNRI could be a first-line treatment if you want to try medications. And finally, REM sleep behavior disorder. Well, sleep hygiene should be a first-line treatment because it may reduce the REM behavior disorder if the patient is getting better sleep. And then melatonin is frequently used, and there is effect that it can be helpful, and there is evidence that it can be helpful. Two small prospective studies and a few small retrospective studies. It's generally well tolerated, usually administered some 30 to 120 minutes before bedtime in doses ranging from 3 to 12 milligrams. And if patients are having violent REM sleep behavior disorder, observational studies suggest that clonazepam 0.5 to 1 milligram at bedtime can be helpful. Clonazepam can cause dizziness, can cause ataxia, etc. So this should only be reserved for patients where the symptoms really are dire. So I've gone over, but maybe I'll take 2 minutes to cover the frontotemporal dementias. Um, Frontotemporal dementia comes in with two major phenotypes. One is the behavioral variant FTD, and the other is primary progressive aphasia. And as the name suggests, behavioral variant FTD manifests primarily with aberrant behaviors. In primary progressive aphasia, patients present predominantly with language symptoms, but invariably, as the condition progresses, they will develop some BVFTD-like behaviors. These are qualitatively different for most patients, and certainly the magnitude may be different. And we could have a whole really interesting webinar on that topic at some point in the future. The diagnostic criteria for behavioral variant FTD involve five specific uh, groups of behavioral changes. So by definition, the BPSD is part of the disease. So one is behavioral disinhibition, which is socially inappropriate behavior, loss of manners or impulsive decisions. One is apathy or inertia. One is loss of sympathy or empathy. So that is all wrapped together in a deficit of theory of mind. So the inability to impute other people's mental and emotional states. Early perseverative stereotyped or compulsive and or ritualistic behavior, which can be tic-like behaviors, complex OCD-like behaviors, or stereotyped speech sounds or phrases. And then hyperorality and dietary changes, altered food preferences, binge eating, and oral exploration of inedible objects. And even though this is not in the modern diagnostic criteria for BVFTD, people who see these patients know that often just general utilization behavior, this kind of infant-like need to touch and grasp everything in your environment, is often a part of this condition. So again, with the non-pharmacological management, the studies are few and methodologically challenging, so there is no substantive evidence based. Proposals are, again, look at the environment, and particularly for FTD, reduce overstimulation of lightning, noise, the amount of people in the room, clutter, simplify social interactions because they can't get the social cues and they have those difficulties with theory of mind. Avoid social interactions that have a high probability of eliciting problematic behaviors. But this strategy in and of itself is often very challenging for caregivers who mourn the loss of being able to go out to a restaurant or being able to go out to the movie theater. Tailored activities program, there are case reports of a structured intervention where you really focus on getting the patient to do something that they really liked to do, if they like to do puzzles or whatever it is. And then if there are specific problematic activities like, reckless spending, falling prey to scams and that sort of thing, then curtailing access to problematic activities and to money can be an important part of this. Caregiver intervention, so just general education on these symptoms and the disease. And for that, there's a lot of good information available through the Association for Frontotemporal Dementia. Access to appropriate support groups. So an Alzheimer's support group may not give all the support that a caregiver or somebody with frontotemporal dementia needs. And then again, providing specific antecedent behavior consequence training to caregivers, as is provided to healthcare workers. That's shown some promise in small observational studies. Behavioral intervention, so positive reward, and I don't mean to belittle the patients, but in some ways, this frontal impairment is very much like treating a toddler. And so, if the patient is refusing to shower, sometimes providing a treat for going into shower will be helpful. There are multiple case reports that suggest that a tailored substitution for compulsive behavior can be useful. So, for example, a patient who was obsessively checking the tire pressure in all the streets parked parked in the car, all the cars parked in the street, sorry, could be given a fidget toy to reduce that type of behavior, lollipops to reduce the compulsive vocalization, and somebody who had a tendency to touch and sexually touch people, given a plush toy to fondle the toy instead of people. This required skilled interveners, a keen and repeated observation of the effects of these types of interventions. So they're highly individualized treatment plans. And just very briefly, we'll talk upon pharmacological management of BPSD and FTD. So unlike Lewy body disease, there are several small studies that suggest there is no benefit on cognition and neutral to negative effects on behavioral and or motor symptoms in FTD. So this is not used in routine practice. Antidepressants, however, there does seem to be more of a role here for boosting the serotonergic system. And this is not just for the treatment of depression, but also for the treatment of some of these compulsive behaviors. So in this meta-analysis, they looked at outcomes of improvement in disinhibition, in irritability, in aggression, and aberrant motor activity. So not even really looking at depression here. And they see that overall, in randomized controlled trials, there were 3 randomized controlled trials studied here. This favored SSRI, and in uncontrolled studies case control studies or observational studies, also overall this favors serotonergic medication. These include trazodone and some of the SSRIs that you see listed here. So trazodone is frequently used and SSRIs are frequently used in this population. There are small case series that support the use of the same antipsychotics that are often used for Alzheimer's disease. In Canada, risperidone and aripiprazole have an indication for risperidone and brexpiprazole have an indication for the treatment of BPSD. But we have to be very careful when we use antipsychotics, as FTD patients may be at higher risk of extrapyramidal symptoms for reasons I won't go into today. So really only use these if the symptoms are severe. And finally, some really homegrown research here, a clinical trial that showed that a single dose of oxytocin improved agitation scores. This was oxytocin lasts about 8 hours. So within a week, this had gone back to normal, suggesting that it's not a placebo effect. And very interestingly, it showed an improvement in the capacity to understand emotional state of anger in an experimental paradigm. So showing that this oxytocin may help to reduce that deficit in theory of mind that leads to aberrant social behavior. This has been followed up by another small study from the same group, but it hasn't really come into mainstream clinical practice, probably for a variety of logistical reasons. So something that needs to be studied more carefully. And there are other drugs that show promise in small case series. Stimulants may show benefit on impulsivity in small case studies and case series. There is a combination of dextromethorphan and quinidine, which is used to treat pseudobulbar affect, which is pathological laughing and crying. That combination is not available in Canada, but it can be compounded in a pharmacy. There was an interesting case report of topiramate used to treat alcohol binging in a patient where hyperorality involved excessive alcohol consumption. And when I was at Baycrest with Dr. Friedman, we published a small case series of clomipramine, which had been used to treat refractory compulsive behavior. So the bottom line is that a lot of the treatment right now is experience-based rather than evidence-based. And so often for challenging cases, you need to see somebody who sees quite a lot of cases of frontotemporal dementia to get the right advice. So I will, the conclusion slides are kind of summarizing this. I'll leave them here for you to read because I know we've cut into the Q&A, and that's probably the part that people are wanting to get to.
Great. Thank you very much for that. Yeah.